Right, for trauma at the ankle and the foot, so we're done with the review, we're done with the routine radiologic evaluations, we're done with the advanced imaging evaluations. We're going here now. All right, so diagnostic imaging for trauma of the ankle and foot. In adults, the ankle is the most frequently injured major joint in the body. Consequently, ankle radiographs are among the most frequent ordered studies in the emergency department, exceeded in frequency only by chest and cervical spine radiographs. However, only a small percentage of these patients will have a fracture that requires definition by radiography. To minimize unnecessary radiography and help the clinician decide when a radiograph are or are not necessary, guidelines that are based on the patient's clinical presentations have been established, commonly known as the Ottawa ankle and foot rules. These guidelines state that the radiographs should be ordered after ankle or foot trauma if the patient is unable to bear weight and has has a point tenderness in either the malleolar zone, midfoot zone, base of the fifth metatarsal, or the navicular. Studies have shown these guidelines to be 100% sensitive for detecting significant fractures. Radiograph examination of the ankles include an AP, lateral, and mortise view angles, and the foot examination would be AP, lateral, and oblique views. Ankle and foot exams need not be performed if pain can be localized to one area or the other. For the advanced imaging for the ankle and the foot, radiographs are recommended by the ACR as the initial study for all acute conditions and all chronic conditions. Advanced imaging is used after the radiograph findings are either insufficient to guide treatment or after the radiographic findings are negative when further injury is suspected. CT and MRI are often complementary studies in defining the characteristics of pathology, and subtle fractures that are difficult to detect on radiographs are best seen with multi-detector CT, or CT is also used in evaluating intra-articular fractures, complex fractures, and positions of comminuted fractures. Stress fractures can also be identified by MRI because it is best for identifying bone marrow edema, which can be interpreted as a biomechanical stress reaction of bone. MRI is also recommended for suspected osteochondral injuries, tendon abnormalities, joint instabilities, or pain of uncertain etiology if radiographs are negative. MR arthrography may be used to evaluate ligamentous and cartilaginous injuries or evaluation of ankle impingement syndromes. And diagnostic ultrasound is appropriately for the evaluation of some tendon abnormalities and ankle impingement syndromes. So we first start with sprain at the ankle. Okay, so the precipitating force in ankle sprains is usually an inversion stress, accounting for 85% of all traumatic conditions at the ankle. And the degree of damage caused is dependent on the direction and magnitude of applied force. Injuries may thus range in severity from minor overstretching of the ligament, affecting little functional loss, to ligamentous rupture or avulsion, creating ankle joint instability and significant functional impairment. The most severe injuries involve ligamentous disruption with associated fracture or fracture dislocation. We have two types of sprains. We have an inversion and an eversion sprain. In Figure 14.56, this is an inversion sprain, and sprains due to inversion stress damage the lateral collateral ligaments, and the anterior talofibular and calcaneofibular ligaments are the most frequently injured components of the lateral collateral ligament system. Inversion sprains are the most common sprains, and the result damage is usually ligamentous without any bony involvement. In Figure 14.57, this is actually a sprain, an eversion sprain, and these eversion stresses damage the medial collateral ligament, and forceful eversion stresses are generally associated with bony damage because the medial collateral ligament has so much tensile strength, kusgan siya, that avulsion fractures and other fractures will often occur before the medial collateral ligament itself fails structurally and sustains damage. So there are different types of associated injuries: severe sprains, disrupted other structures. Usually they are avulsion fractures, which are due to tensile pulls of the ligaments at their distal or proximal points of attachment. We have tearing of the distal tibiofibular syndesmotic complex, which is associated with either eversion or eversion stresses. Instability from sprains is due to tearing of one or more of the three principal stabilizing ligaments. Sinus tarsi syndrome, which I mentioned a while ago, is caused most often by an inversion ankle sprain, but can also be a result of repetitive impingement of the soft tissues and ligaments in the sinus tarsi due to an extensively pronated foot. Lastly, you have impingement syndromes are usually defined as painful mechanical limitations of full ankle range of motion secondary to an osseous or a soft tissue abnormality. It can be the one I mentioned a while ago, the anterolateral ankle impingement at the anterolateral gutter, the syndesmotic impingement at the distal tibiofibular syndesmosis, and a posterior ankle impingement at the posterior tibial region. So, impingement develops post-injury and is related to persistence of inflammation and synovitis, resulting in scar tissue, hypertrophied soft tissue, and ultimately painful impingement of soft tissue osseous structures during normal joint range of motion. For the imaging evaluation, usually needed when an associated fracture is suspected. So joint instability can be revealed on routine radiographs or stress views by observing an abnormal position of the talus or increased width of the ankle mortise. So we see here there is an increased width of the ankle mortise once again, and then we have because of a stress fracture. Okay, so in post-injury chronic pain situations, radiographs are indicated as a first imaging study. In patients with anterior ankle impingement may develop spurs at the tibia or talus. Having the patient adopt a lunge position that reproduces their pain may show bone-on-bone impingement and a weight-bearing radiograph. And patient with posterior ankle impingement may show an enlarged posterior tubercle of the talus or an os trigonum, a common accessory bone at the talus that may become injured. MRI is an imaging technique of choice because of its advantages in identifying osseous and soft tissue abnormalities, and ultrasound may be useful in identifying some synovitic lesions, especially within the anterolateral gutter. So for this one, for the treatment, usually restorative stability of the ankle mortise may be conservative through cast immobilization or surgical through screw fixation, followed by immobilization for several weeks. Rehabilitation after the immobilization phase is extensive and focuses on restoring joint arthrokinematics, osteokinematics, strength, and if required, functional ambulation and athletic skills at the ankle and the foot. Sprains and impingement syndromes are treated with physical therapy to reduce inflammation and gradually restore normal flexibility and strength. And in severe cases of impingement, arthroscopic debridement of hypertrophic soft tissues or spurs may be performed. Alright, so next up we have tendon pathology. So I believe you're already familiar with these terms. So tenosynovitis, tenosing tenosynovitis, tendinitis or tendinopathy, tendinosis, and tendon rupture. So you have to know what are those. Alright, and the tendons of the ankle and the foot can be divided by their location into 4 groups. The characteristics are briefly outlined, as one major posterior tendon is the Achilles tendon. The 2 lateral tendons are the peroneal brevis and the longus, and these tendons are principally evertors of the foot. You also have the medial tendons as the posterior tibial tendons, the flexor digitorum longus and the flexor hallucis longus. And lastly, you have 4 anterior tendons, the anterior tibial extensor hallucis longus, extensor digitorum longus, and the peroneus tertius. Alright, so just read on them. Alright, so also there are often injured during inversion sprains, and longitudinal split tears of the peroneus brevis are also associated. So for the imaging evaluation, MRI is routinely used to evaluate tendon abnormalities in the axial plane. Normal tendons appear round, oval, or flat, and evaluation assesses both the girth of the tendon and the signal of the tendon, so which is seen in the figure 14.61. So the normal signal intensity of tendon is usually low on all sequences, and there are 2 exceptions. One, Many normal tendons will show increased signal near their insertion on bone, and this occurs because tendons may fan out near their insertions, and high signal fat tissue may be interposed between tendons or tendon fibers. And number two, the other exceptions is the magic angle effect described previously, and normal tendons oriented at 55 degrees to the magnetic field will show an artificially high signal. So high signals within tendons is usually abnormally high. Signals will present if partial or complete tear exists, if a fluid present is in the sheath, which is diagnostic of a tenosynovitis if the fluid surrounds the entire circumference of the tendon, so it's like this one, entire circumference, and then focal loculated collections of fluid in the sheath, indicative of focal areas of synovitis or fibrosis, or characteristic of stenosing synovitis. If myxoid degeneration has occurred due to aging or chronic overuse, and if xanthomas, tumors, or gout deposits are present. So you can actually identify them in MRI imaging. So for the treatment, I'll leave this up to you. And then next are the fractures at the ankle. So fractures and fracture dislocations are common injuries at the ankle, and the predisposing force mechanisms are often similar to those causing sprains, and fractures here are frequently seen to occur in combinations with ligamentous ruptures, avulsions, and other fractures. So this is the mechanism of injury. Usually there are axial and rotational loading, and then which causes the instability. So you have the radiologic evaluation, and then you have classifications. Okay, so for the classifications, there are actually numerous classification systems exist to classify ankle fracture via injury mechanisms and structural damages, and the purpose of classification systems is to aid diagnosis and treatment decisions and to assess treatment outcomes. The most basic description in common usage describes the fracture set anatomically as one of the following, which is in figure 14-62. So a unimalleolar fracture indicating fracture of either the lateral or the medial malleolus, which is seen in letter A. In letter B is a bimalleolar fracture indicating fracture of both the lateral and medial malleoli. And in letter C, you have a trimalleolar fracture indicating the fracture of both malleoli and the posterior rim of the tibia, sometimes called the third malleolus. Other fractures involving the ankle joint may be seen in this one, in 16-63. This is an example of a bimalleolar fracture. Okay, in this one, in 64, 65, and 66, figures would show a shaft fracture of the tibia and the fibula. So this is the shaft fracture here, and then this is the treatment with screws. And then you have a comminuted fracture, and an impaction fracture, and a stress fracture. So this is the stress fracture. This is the impaction fracture here. All right. So for the treatment and also for the complications, I'll leave that up to you. And then we go to the fractures of the foot. So foot fractures are generally described as being located at the hind foot, midfoot, or forefoot. And fractures of the hind foot, the talus and the calcaneus, are common, with the calcaneus being the most frequently fractured tarsal. With the exception of the navicular, which is noted to sustain stress fractures and also avulsion fractures of its tuberosity, isolated fractures of the midfoot tarsals are uncommon, and fractures of the forefoot metatarsals and phalanges are very common due to the anatomic location. So we have first, we go to hindfoot fractures, calcaneal and talar fractures. So we'll go first with calcaneal fractures. I'll leave the reading up to you. More or less, the mechanism of injury is sustained during falls from a height in which the individual lands feet first. And then for the classification, it can either be an intra-articular or the extra-articular. So usually it includes either the subtalar joint, or it either spares it or involves it. Alright, so this is an example of the classification, the row classification of calcaneal fractures defined in injury patterns. So familiarize this one. And then you have a fracture of the calcaneus here, seen in the pictures. And then you have also another fracture of the calcaneus. Alright, so these are the radiologic evaluation, the treatment, and the complications. I'll leave the reading up to you. Next up would be the talar fractures. Fractures of the talus occur second in frequency to calcaneal fractures, and the mechanism of injury would be there's a large force that is applied through a dorsiflexed foot. For example, when the driver slams on the brakes in an auto collision or an MVA. For the classifications, once again, there are either a articular cartilage, an all talar fracture considered to be intra-articular, and the most common it would be the head, the body, and the neck. Alright, so this is the radiologic evaluation, and then okay, and then once again another radiologic evaluation, an arthrogram of the ankle, which shows an osteochondral defect revealed at the talar part. Alright, so for the treatment is this one. Complications. And then we go to the midfoot fractures. Navicular fractures. So these are actually midfoot fractures are the relative immobility of the midfoot minimizes its susceptibility to isolated fractures, and fractures occurring in this region are often associated with other fractures or dislocation patterns. Sprain and fracture subluxations or fracture dislocations can occur at the transverse tarsal joint and tarsometatarsal joint, where the relatively rigid midfoot attaches to the more mobile hindfoot and forefoot. In general, however, dislocations occur much less frequently than fractures. A relatively rare fracture dislocation at the tarsometatarsal joint, also known as the Lisfranc joint, is such an example seen in figure 14.75. So this one here. The mechanism of injury of a fracture dislocation is usually a high-energy trauma. Surgical reduction is often necessary to restore alignment and function. For the navicular fractures, I'll leave the reading up to you. Alright. And so this is an example of a CT showing a stress fracture in the navicular. Next up is the forefoot fractures. So we have mechanism of injury of the forefoot fractures and also phalangeal fractures in itself. So this is the forefoot fractures. Forefoot fractures. Okay, and then this is the phalangeal fractures. So I'll leave the reading up to you. And then so we go with deformities of the foot. Oh, this is a fracture of the base of the fifth metatarsal, so I think you can really appreciate it there. Okay, so for deformities of the foot, there are abnormal foot positions, maybe congenital or developmental, or may result from traumatic conditions or neuromuscular impairment. And the entire foot may exhibit structural or anatomic deformities, or the deformity may be confined to a segment of the foot, such as the forefoot, midfoot, or the hindfoot. We go first with Hallux Valgus. So for Hallux Valgus, this is a deformity in the forefoot in which the first metatarsal is deviated medial and great toe is deviated laterally greater than 10 degrees. And the etiology is varied, seen here. And associations have been made with biomechanical dysfunctions, improper footwear, and predisposing congenital factors such as wide first intermetatarsal angles and pes planus. Females are affected with much greater frequency than males. For clinical presentation, clinically, the first metatarsophalangeal joint undergoes friction and stress in this deformity, and a bunion formation on the medial side of the joint is a common occurrence. Although some patients may be asymptomatic, the most severe cases of Hallux Valgus significantly alter function and causes pain, especially if the DJD or degenerative joint changes progresses. For the radiologic evaluation, the AP view of the foot demonstrates this deformity, and the first intermetatarsal angle describes the degree of medial deviation of the first foot, or the first metatarsal. So, greater than 10 degrees, known as the metatarsus primus varus. So I'll write this one down. metatarsus primus varus. Alright, so for the treatment, may consist of corrective orthosis, bunionectomy, arthrodesis, or a resection arthroplasty. So, rehabilitation focuses on restoring joint arthrokinematics and sufficient dorsiflexion at the joint to permit normal toe-off in gait cycle. So for pes cavus, sometimes called as clawfoot, the medial longitudinal arc is abnormally high. So this one here. Alright. For etiology of pes cavus is known in approximately 80% of patients. Conditions including malunion of the calcaneal or talar fractures, sequelae of burns or compartment syndromes, residual talipes equinovirus, or neurologic disorders such as Charcot-Marie tooth disease, muscular dystrophy, poliomyelitis, syndromyelia, Friedreich's ataxia, cerebral palsy, or spinal cord tumors. And the other 20% of cases are idiopathic and usually non-progressive. For the clinical presentation, patients may present with lateral foot pain secondary to excessive weight bearing, metatarsalgia, plantar keratosis, and ankle instability. For radiologic evaluation, seen in figure 14-18, a weight-bearing radiograph are essential for inspection of the DJD, calcaneal positions, and forefoot alignments. A calcaneal pitch over 30 degrees is indicative of pes cavus. The tarsal-metatarsal angle, as seen on the lateral view here, gives a value for the height of the arc in the sagittal plane. So in here. Okay, so that should be greater than 30 degrees. Alright. Conservative treatment includes strengthening and the use of orthotics. Extra deep shoes are needed to offload bony prominences, and lateral wedges may be applied to the outside sole to shift weight off the lateral foot. Bracing may be helpful for flexible deformities or foot drop. Surgical treatment involves both soft tissue and bony procedures. Examples include tendon transfers, osteotomies, plantar fascia release, and joint arthrodesis. We have pes planus. This is also known as flatfoot, categorized as being either a rigid, pathologic, or a flexible, which is physiologic characteristic. A flexible flat foot demonstrates a low arc on weight bearing and a return to a more normal arc when non-weight bearing. A rigid flat foot demonstrates a low arc whether weight bearing or non-weight bearing. So this is an example of a pes planus. Okay. So usually there are flat feet in children. So a flexible flat foot is considered normal in young children and usually resolves with growth and maturity. Unfortunately, some children do not outgrow the flat foot, and the deformity persists lifelong. Early interventions in the treatment of flexible pes planus is highly controversial, and some practitioners recommend no treatment for the painless flat foot. Others who treat the damaging effects of excessive pronation in adults argue that much pathology can be curbed if the condition is addressed in childhood. For the etiology, usually widely varied and include torsional abnormalities, muscular imbalance, ligamentous laxity, neuropathy, obesity, agenesis of the sustentaculum tali, Calcaneal Valgus, equinovirus or valgus of the tibia, limb length discrepancy, compensated forefoot varus, and an external tibial ossicle. Biomechanically, the condition is primarily one of the peritalar subluxation that occurs secondary to excessive pronation of the subtalar joint, and etiology of rigid flat foot includes tarsal coalition and congenital vertical talus. For the clinical presentation, usually the flexible flat feet in adults may or may not be painful. Rigid flat feet with tarsal coalition are seen to become symptomatic in the second decade of life, when the foot ossifies and greater stresses are put on the tarsals owing to increased body weight and the increased activity of sports or work. For the radiologic evaluation, lateral radiographs may show deviations in calcaneal inclination, talar declination, producing a negative talo-metatarsal angle or a medial column sag at the talonavicular or navicular cuneiform deformed joint. A talar beak is a secondary change due to limitations of the subtalar joint found here in figure 14.83. That's the talar beak. This one, talar beak. And then the AP radiograph may show altered talonavicular congruity and cuboid adduction. Tarsal coalition is the bony or fibrocartilaginous connection between two or more tarsal bones, and the talonavicular and calcaneonavicular coalitions are the most common and are bilateral in over 50% of known cases. Coalitions are usually identified on radiograph, although CT and MRI allows for more precise determination of the articular involvement. So here, as you can see, you have in the MRI, this is a CT scan. Okay, CT scan of the foot and then left foot. So as you can see here, you have the narrowing of the subtalar joint. Okay, and then coronal of the feet on the same exam allows the comparison of the right foot. So this is the right foot, and this is the left foot. Okay. Alright, so as you can see, there are talar coalitions found here. This is the talar coalition here, and this is the calcaneal or the talocalcaneal coalition over here. This one. Alright. So for the treatment, we still have congenital vertical talus, so found in 18.85 here. So is the most serious pathologic flatfoot and may occur in association with other congenital anomalies such as myelomingocele, arthrogryposis, and developmental hip dysplasia. At birth, the foot is dorsiflexed and the arc is convex. Radiographs confirm the diagnosis. Alright. For the treatment, you have conservative treatment includes the use of orthotic heel stabilizers from the time of child begins walking until a normal supinatus is developed in the forefoot to hindfoot relationship near age of 6. At this time, functional orthosis can be effective, and functional foot orthosis placed the subtalar joint in neutral via rigid control of the hindfoot at the stance phase of gait cycle. Another option is an ankle foot orthosis that functions in the stance phase as well as swinging phase by exerting control over the ankle and tibia. Surgical treatment for painful flat foot after failure of conservative treatment is varied, and some subtalar joint arthroeresis is implantation of a disc that's size of a pencil eraser, and in the sinus tarsi is block supination of the subtalar joint. The implant is outside the joint and is easily removed at maturity or if the patient does not tolerate it. Subtalar arthroeresis is utilized alone or in combination with heel cord lengthening, medial arc stabilization, or both. Surgical intervention for coalition includes resection of the bridge and interposition of fat, tendon, or muscle at the coalition site. In PT, usually is involved to help correct the dynamic factors that influence the kinetic chain of limbs, including the joint mobilization, joint balancing, flexibility, functional limb length modifications, and orthotic fabrications. Alright, so I think this is the last of the foot deformity. So we have foot or talipes equinovarus. This is the most common congenital deformity of the lower extremity and commonly known as the club foot. So talipes is a term designating deformities of the ankle and the foot. For the etiology, the club foot during fetal development appears to be multifactorial. Both genetic and environmental factors are implicated, and the less severe form of deformity known as postural clubfoot are associated with abnormal intrauterine positioning. Risk factors include a family history of condition. Boys are predominantly affected, and the incidence is 1 in 800 live births. For the clinical presentation, there is a bilateral involvement in up to 50% of the cases, and deformity may range from mild and flexible to severe and rigid. The Hallmarks of deformity includes the following. Number 1, an equinus or plantar flex position of the heel, inversion of the subtalar joint with varus position of the hind foot, a metatarsal adduction with varus position of the forefoot, and the last is the most severe case, subluxation or dislocation of the subtalar or talocalcaneal navicular joint, and this element cannot be evaluated on radiograph before the navicular ossifies by the age 2 or 3 years old. For the radiologic evaluation, radiographs are of limited value in assessing Talipes equinovarus at birth because the bones are minimally ossified. Radiographic assessment is significantly later in monitoring osseous growth and development and assessing surgical outcomes. For the treatment, conservative treatment begins immediately after birth to take advantage of an adaptable flexibility. So the foot is manipulated into a more normal position then it's casted. Recasting and repositioning and continue at intervals. This is usually complete after 3 months, and then after the foot is so realigned, normal position is maintained through stretching exercises, night splints, and orthopedic shoes for up to several years as needed. Surgical treatment is required when conservative measures fail or to correct contractures or irreducible joint subluxations. Rehabilitation is involved extensively to restore strength, flexibility, and function, as well as to facilitate normal developmental motor skills, and the prognosis is generally good for functional foot and pain-free ambulation. Alright, so we'll proceed first with foot anomalies. This would be the last part. Finally. Alright, so we have accessory bones. So accessory bones are anomalous bones that usually form because of a failure of one or more ossification centers to unite with the main mass of bone. Accessory bones appear with some frequency at the foot, and studies have reported an incidence as high as 30% in adult. And accessory bones may be seen radiographically at various locations in the foot. The locations and the names of these are presented in figures 14-87 here. Alright, so the most common occurring accessory bones of the foot are the os trigonum, the os intermetatarsum, and the os tibiale or the accessory navicular found in figure 14-88. Okay, so accessory bones can complicate the evaluation of foot injuries if they are present in the areas of suspended fractures, and comparison films are not always helpful because accessory and sesamoid bones are not always bilaterally symmetrical. In general, accessory bones are differentiated from acute fractures by the presence of an intact, smooth cortical shell with an underlying line of increased density. In contrast, acute fractures will have an irregular cortical surface and no appearance of increased density beneath surfaces. Right, so I think that ends up the ankle joint or ankle and the foot. And then just a quick summary of key points. We talked about the routine radiograph evaluations of the ankle, the AP view, the AP oblique view, or the mortise view, and the lateral view. We discussed about the routine radiologic evaluations of the foot, specifically the AP, the lateral, and the oblique view. We had the advanced imaging, wherein the CT scan, the CT exam, and the MRI. The ABCs, alignment, bone density, cartilage, edema, and soft tissues. For trauma radiography, we talked about the Ottawa criteria. And also, advanced imaging is used when radiographs are insufficient to guide treatment or after the radiographic findings are negative, when further injury is actually suspected. We talked about the ankle sprains, the different tendon pathologies, ankle fractures such as the unimalleolar fractures, bimalleolar, and the trimalleolar. And the goals of treatment is to stabilize the fracture site and reestablish an architecture of ankle mortise. We also talked about the fractures at the foot, the hind foot, the forefoot, and the midfoot. And then also lastly, the deformities of the foot, the Hallux Valgus, pes cavus, pes planus, and the Talipes equinovarus or the clubfoot. Then we also talked about the accessory bone. Alright, so I think that's it. Thank you for listening.